Hi, everyone. This is a quick overview on potassium IV fluid. It's very important to understand that there are times when the patient has low potassium levels and they are not able to consume the potassium, to, to take the potassium PO. We need to replenish the potassium immediately, but not too fast in order to prevent the patient to get any complications like cardiac dysrhythmias. So potassium comes in IV piggyback. Never, and I repeat, never give it IM, sub-Q, IV push. It cannot go into that route. So IV potassium is given to treat and prevent hypokalemia. Another word for hypokalemia is low potassium. Anything less than 3.5, but we really start treating when it's severe hypokalemia, 2.5 to 3. We give the IV when oral potassium cannot be used or when rapid replacement is needed. Again, why is this important? Potassium is essential for normal heart rhythm, muscle contraction, nerve impulse transmission, respiratory muscle function. What is the normal rate for potassium? Correct. 3.5 to 5. So we give this when the patient has symptomatic hypokalemia, unable to take any oral fluids, they have ongoing GI losses. When the patient has diabetic ketoacidosis, or initially their potassium will be elevated. But as you start replenishing the patient with fluids, because they're severely dehydrated, the potassium starts to drop. And you have to look at the potassium levels before you give insulin, right? So as you're looking at the potassium levels, you notice that it's low. The doctor might ask you to give IV because this patient is so unstable. So why must potassium be diluted in fluids? It's highly irritating. It irritates the veins and it could stop the heart if it's given too fast. Never give this medication IV push or bolus. Even though someone was to tell you that, don't listen to them. It must always be diluted. You have to infuse it on a pump. Give the recommended rate. The maximum recommended rate is 5 MEQs per hour, never to exceed 20 MEQs under any circumstances. If the patient is to get more than 10 MEQs per hour, they need to be placed on cardiac monitor for cardiac changes and an infusion device. It always has to go on an infusion so that we could control the rate. So make sure the peripheral site is good. If the patient says it's burning, you have to look at it and you have to tell the doctors. So they might require continuous cardiac monitoring when you give it more than 10 MEQs. In critical care settings, higher rates may occasionally be used under intensive monitoring and institutional protocols. So like I said, never give it IV push. This is a high alert medication, so you need another nurse to double check it with you. Here are the EKG changes for hypokalemia. It will be flat or inverted T waves, ST depression, prominent U waves. You can see here prominent U waves, and ventricular dysrhythmias. So it's not going to be anything related to the P waves, but it'll be something related to the QRS because that's related to ventricular. So when you give a patient with low potassium any type of treatment, you also have to look for signs of hyperkalemia. EKG changes for hyperkalemia would be tall peak T waves, widened QRS, bradycardia. If it's not recognized early, ventricular fibrillation and asystole. As nurses, you have to use an infusion pump. Monitor the IV site frequently for pain, redness, or infiltration. Monitor the potassium levels during therapy. If you're giving potassium more than 10 MEQs, monitor the cardiac rhythm if appropriate. Teach the patient to report burning or pain at the IV site. Never mix potassium without verifying compatibility. So the major adverse effects of potassium, it's burning during infusion, phlebitis, hyperkalemia, cardiac arrest if it's infused too rapidly, extravasation, which means it causes tissue injury. Never IV push potassium. Never give it undiluted. Always use a pump. Verify adequate urine output before administration. Monitor EKGs in high-risk patients. Recheck potassium after replacement. Here is the difference between hypokalemia and hyperkalemia. IV potassium is used to treat low potassium levels when patients cannot take it by mouth or need rapid replacement. Even though they need rapid replacement, doesn't mean that you're going to give it bolus. Potassium is essential for normal heart rhythms, for nerve and muscle function. So because potassium can cause fatal arrhythmias, it can't be given too quickly. It must never be given IV push. Notice how much I say that. I don't want you to get nervous as new nurses or even during a simulation. It should always be diluted, administered on an infusion pump, and given at the recommended rate. You already know what the recommended rate is. And if you have any questions, you don't remember, look it up. Before administering IV potassium, nurses should verify kidney function and urine output. How will you understand kidney function? You check the potassium levels. You check the BUN and GFR. This is a high alert medication and requires careful monitoring. No IV push. It's a high alert medication. It needs to go on the IV slowly. It needs to be diluted because it burns. So just remember these things because it's important. This is not just something that you memorize. This is something that you will be doing real life. And a lot of patients get this medication, and you need to understand why they need it, why you need to look at the electrolytes, why you need to check the kidney functions, and when should you stop this medication.